So hello everyone, I welcome you all to the knee injuries and rehabilitation module. Here I'm going to talk about different knee injuries and then how to rehabilitate and then how do we make the player to return to sports. So the learning outcome of the module is at the end of the sessions you will be able to understand the anatomy of knee and its structures. You will be able to understand the importance of assessment methods in knee injuries, and then you will be able to develop rehabilitation program in knee injuries. And before we get into anatomy and biomechanics, like I'm going to discuss about myths and facts in knee rehabilitations. So those who created medical myths are worthy of praise, as they are those who bust them. It is those who cling to them after they are proven wrong that should be criticized. So for the ignorance or lack of skepticism, here the skepticism is the essence of academic life. Sometimes it just hurts even though the knee injured the whole leg seem to be healthy in every way that we can measure knee health. And if that seems bit odd, you haven't seen nothing yet. So the first point what I would like to introduce is, so the pain in the PF joint, patellofemoral joint, does not appear to be associated with any identifiable tissue generation or a damage, a dysfunctions or a malfunctions, asymmetry or weakness. So knee pain during adolescence and patellofemoral pain in particular especially is in most cases present after 2 years and thus may not be self-limiting. So here a greater focus on early reductions and prevention of knee pain during adolescence is needed. And then the ACL, anterior cruciate ligament reconstructions, is performed to augment knee stability. The long-term follow-up doesn't show a difference between the patients treated conservatively or operatively with respect to osteoarthritis or meniscal lesions of the knee, as well as activity level, objective and subjective functional outcome. What the current evidence says, that the current evidence indicate that the people following a ACL rupture should receive a non-operative interventions, which means not the conservative. No difference between conservative and non-operative, but as a professional we should use the non-op protocol. So the for ACL, if the patient is diagnosed to have ACL insufficiency, so they should receive a non-operative interventions before surgical intervention is considered. The injury prevention program do not prevent injuries. Make sure the injury prevention program do not prevent injuries. Perhaps they reduce the risk of sustaining a future injury. Secondary preventive measures to reduce chronicity and recurrence. Obtaining a symmetrical knee extensions, even if it involved hyperextension, is more important than just achieving 0 degree of knee extension, especially after ACL lock. So following ACL lock, a very small percentage of athletes are ready to by 6 months to return to sports. In fact, recent research recommends delaying return to sports at least 9 months, and others suggest 2 years to return to sports. So resisted open kinetic chain quadriceps exercises are not harmful following ACL lock. To ensure the best outcomes, timing, we have to talk about the timing, load and range of movements must be monitored. And when I talk about meniscus, the meniscus tears are common in symptom-free, general, middle-aged and older populations with or without signs of radiographic knee osteoarthritis. Similarly, in patients with knee trauma, meniscal tears are frequently seen in uninjured contralateral leg. So the OA knee is a progressive disorder, and then TKR is lifestyle surgery. If everyday activities are causing pain or interfering with your day-to-day activities, you may benefit from physiotherapy interventions or total knee replacements. So the delaying total knee replacement after being advised lowers the patient's quality of life, not only before the operations but even for up to 2 years following surgery. So those are the myths and facts in rehabilitation. So we are moving to chapter 2 called Functional Anatomy and Biomechanics. So before we get into the mechanism of injury, what are the types of injury? How do you design a rehab? Like it's a basic to understand about functional anatomy and biomechanics of knee joint. So as you're all aware that the anatomy follows functions and it's a teamwork. So it's not the single man army where, like, for a knee joint it's a hinge joint. So where we have a femoral condyle, tibial condyle, fibula, and then we have a muscles around the knee joint. So the structures which presents in the anterior side as well as in the posterior and on both sides, medial and lateral and intra-articular structure. So anatomy always follows a function. It's a teamwork, like what I said before. And then the complex function of knee is a result of an optimal interplay of bone structures such as I said, femur, ligaments, tendons, muscle, and joint capsule, coordinated by peripheral and central receptors. And when you talk about knee rehab, so what are we going to talk about knee rehab in this module? So we are going to do a pain management as a physiotherapist. If any patients or any athlete or any sports individual comes to you with knee pain, so primarily we are going to do a pain management and stability management and load management. So the knee rehab can be categorized into three. So the pain and stability and then load. So like when you receive an athlete or a player or any sporting individual, so what do you think, what are the common presentation of knee joint? So the patient may present to you with the pain or pain with instability or feeling stiff or they might injure the meniscus or cartilage tendon, or could be inflammatory pathology or degenerative or post-operative pathology. So those are the common presentation of knee joint. And what we are going to see now, it's a simple basic knee examinations. So we are going to talk about history and subjective examinations. So first of all, as I hope I have discussed in the previous class, so the site of function is site of pain is always a site of dysfunctions. So when we are talking about knee joint, like now we are going to discuss about knee examinations. So each and every one has its own style to follow, unique style to follow. But here we'll just divide it and then let's see how we are going to examine the knee. So the site of pain, you should ask for the site of pain. Where is your pain starting arises from or initiating from? So the site of pain is always important. The pain may arise from the anterior portion of the knee or posterior or medial or lateral. And what is the onset of pain? Is it acute onset or previous, so or chronic? And then, so what are the chief complaints? What are the chief complaints that the patients may present to you? So either they may present to you with the pain, knee pain, or knee pain, or a discomfort or a disability. So which is much more important. And then how do we differentiate from the anterior knee pain versus patellofemoral joint pathology versus tendon pathology? And then how we are going to differentiate between meniscal tear and chondral injury and locking or giving away? So either it is instability, or is it from ACL or a locking or a ligament or a meniscus? So cracking versus early degenerations or a popping sound, is there any instability or snapping? So twisting versus impact, it's a load or a twisting. So here the reasoning process called clinical reasoning process called pattern recognitions. We are going to use the pattern recognitions here because that's most important. As experts physiotherapists, we use this reasoning as a process to generate the hypothesis. So following a few accusations, we'll generate a hypothesis and then So whatever the hypothesis being generated, we'll be able to evaluate, and then we'll be able to customize the rehab. So the pattern recognitions plays a vital role in examinations. So what is a pattern recognition here? The pattern recognition is a characteristic for all mature thought in both everyday life and in the real manual therapy. So here the reason for using pattern recognitions, because these patterns form a prototype of frequently experienced situations that individuals use to recognize and interpret the other situations. Mostly in sports physiotherapy, the patterns exist not only in the classical diagnostic syndrome and associated management strategies, but also in the pathological mechanism associated with those syndromes and the multitude of environmental, not only the environmental, physical, psychological, social, behavioral, and cultural factors that contribute to the development and maintenance of patient's problem. So the pattern recognitions plays a vital role in examinations. And then what does objective examinations? So what do you look while the patients enter into a clinic? What are the parameters that you look for? So on observations, we tend to look for the gait pattern of a patient, the way he walks into your consultation room. Okay, and then we are going to assess the functional movement. So you also should observe in the patients standing from sitting positions, and then while walking also we have to look at the foot orientations, either as inverted, everted. And then we should start with the functional testing. So how do you observe the movement? So we have to observe the movement, and also sometimes you have to always look for the joint above and below. So is there any influence from the proximal joint, or is there any influence from the distal joint? So when you observe the movement pattern of any individual or athlete or sports persons, so does the proximal joint influence the affected joint? So the functional testing is very, very important to introduce in the early phase of knee examinations. And then palpations, so like we are trying to palpate in and around the knee. So we are by doing a palpations, we are trying to find is there any effusions or tenderness, as you all aware. And then as you are all so we used to practice in a day-to-day life in our setup. So pain on palpations. So is there effusions? So after palpations, if you're looking for the effusions, is there any effusion in the joint line, or is there any effusion in the suprapatellar pouch or patellofemoral? So if it is there, okay, so you can make it as one of the symptom, joint effusions presence. And then when you palpate, so you have to look for the joint line tenderness on either side, medial and lateral, one. Then the pes answering has to be measured in knee extension position. And then lateral joint line, we are trying to palpate the lateral collateral ligament in the anterior direction, in the anterior region. So we have a patellar tendon, quadriceps, fat pad, quadriceps, bursa, medial retinaculum, lateral retinaculum, medial patellofemoral joint. On our posterior side, we have hamstring tendon, popliteal fossa, a Baker cyst, or gastrocnemius insertion. So those are the structures that really need to look for while palpating or examining the knee. And apart from that, during the objective examinations, we also assess the active assisted range of movement as well as passive range of movement. So if there is any restrictions in the active range of movement, like you have to look for the soft tissue pathology or joint mobility. So as we discussed in the earlier slide, we have to look at both hip and knee. So hip and ankle, sorry. So whether does it influence your knee pain in knee functions or not. And also we need to assess the muscle strength. So especially the quadriceps, hamstrings, agonist, antagonist, and hip abductors. And when you talk about special test, the special test is not an alternative for imaging. So always we have to use the principle called rule in and rule out.